pursuing my master's in nursing education, but also to identify a need on our unit, pre-K. A few months ago, Denise, who's our nurse educator, sent out a questionnaire, and it asked what the learning needs of the unit were. And people had a lot of specific questions, but I figured that I would give you tools to be able to answer those questions, because there's a knowledge gap as to how to address evidence-based practice and what tools and resources that we have here at Tampa General. So the purpose of this presentation is to provide nurses with resources to support evidence-based practice and support the best quality of care for various patient populations. To address a knowledge gap, and evidence shows that when we base our decisions on evidence-based practice, we improve patient outcomes and we improve patient safety. So this is the outline of the presentation. We'll start off with the definition of evidence-based practice and why it's important. We'll go through the Iowa model, and that's Tampa General's, the model that Tampa General embraces as their evidence-based practice model. We will work on creating a PICO question. Do any of you have experience with PICO questions? Stephanie does, all right, great. We'll go through the resources for obtaining evidence, and we have a guest speaker from the medical library that will talk. And we'll talk about, briefly, evidence-based practice implementation based on the Iowa model. The objectives. After this one-hour presentation, you'll be able to describe the importance of evidence-based practice in nursing, demonstrate the ability to form a PICO question, and identify quality resources that can be used to support evidence-based practice. So what is evidence-based practice? There are several definitions, but the commonality amongst those definitions are that it is based on individual clinical expertise. That could be your clinical expertise, expert opinion, the best external evidence. You're going to do a literature search to find out what the best external evidence is, and patient values and expectations. We're a patient-centered hospital, so you're always going to take into account patient values and expectations. So overall, evidence-based practice is the conscientious use and integration of the best available evidence with consideration of one's own clinical expertise and patient values and preferences to improve the outcomes for individuals, groups, communities, and systems. So why is evidence-based practice so important? The Institute of Medicine has set their goals for 2020, and part of those goals are that 90% of healthcare decisions need to be based on evidence. It's no longer acceptable to do things at the bedside that are based on just what we've always done. It's not acceptable to not have evidence to back up our care at the bedside. And evidence-based practice, like I already mentioned, has been proven to improve patient outcomes and reduce medical errors. So I have a video to show. It's got a little bit of humor at the end of it, but I thought it was a good video just to highlight the importance of evidence-based practice.
Evidence-based practice is a systematic approach to practice that emphasizes the use of best evidence in combination with the clinician's experience, as well as patient preferences and values, to make decisions about care and treatment. As nurses, we use evidence-based practice to alter our care when research shows that a change in practice would yield greater results for the patient. Take nasogastric tubes, for example, better known as NG tubes. An NG tube is designed to be fed from the patient's nose into their stomach, where it can be used to suction out the contents of the stomach as needed to promote the patient's return to a healthy state. Currently, nurses are expected to check the placement of an NG tube by first aspirating the tube with a syringe and testing the pH level of the aspirate to determine if the pH reflects that of the fluids in the stomach. Then, the patient will undergo a KUB, or kidney ureters bladder X-ray, to provide an image of the NG tube through the use of a radiology imaging technique. The KUB X-ray can show the clinician if the tube is placed in the proper anatomical position. The KUB X-ray is the gold standard for checking placement of an NG tube, and most hospitals use evidence-based practice when forming their guidelines for proper placement. However, in the past, evidence-based practice was not used often in hospitals, and most nurses checked the placement of an NG tube by auscultating the patient's abdomen while pushing air through the tube with a syringe. Theoretically, the nurse would hear the air being pushed into the abdomen upon auscultation. This was considered an acceptable way to check placement of a tube, but it was often difficult to hear the air in the abdomen, and many other bodily sounds could prevent the nurse from properly hearing the injected air in the stomach. Auscultating the abdomen while pushing air through the NG tube was therefore not an effective way to check placement of the tube, but without evidence-based practice, no action was taken to change this method. Even with abdominal auscultation, NG tubes could end up being placed in inappropriate areas of the body, such as the esophagus, the trachea, or the brain. So instead of removing the contents of the stomach, your patient could have pieces of their brain suctioned out. And we all know the problem this could present: zombies. That's right. Using the old method of checking NG tube placement could ultimately turn your patient into a zombie. If all nurses ignore this evidence-based practice, we potentially turn thousands of patients into zombies. And we all know that zombies create more zombies by feeding on the brains of the living. Eventually, we would have a zombie apocalypse on our hands, and the earth would be destroyed. Clearly, evidence-based practice is wildly important to use in nursing practice in order to preserve the human race. The moral of the story? Don't start the zombie apocalypse. Use evidence-based practice.
How important it is to base our decisions on evidence. Can you guys think of anything that we do at the bedside that is based on evidence? Like procedures we do. I mean, one thing I can think of are our sheath pulls. That is based on evidence. It's based on the fact that you have to wait a certain amount of time before you can pull a sheath if somebody gets given anticoagulant. That's based on proven research and evidence. And that's why we do what we do. This is the Iowa model, and I'm not going to touch on every point, but this is the model that Tampa General embraces as their evidence-based practice model. And I just wanted to point out up at the top, there's two triggers for the start. There's a problem-focused trigger, or there's a knowledge-focused trigger. And a problem-focused trigger could be, something that you're noticing that's occurring on the unit. Let's say you're noticing that when you get TR bands, transradial bands, out from the cardiac cath lab, and you start deflating, the order is to deflate immediately. You may start to notice that patients are oozing even if they've gotten a small amount of heparin. That could become a problem, and that could be a problem-focused trigger for creating an evidence-based practice question. Or you could have a knowledge-focused trigger, and that could be, let's say, new literature, new research comes out on something that we have experience with. I don't know if any of you guys get the American Journal of Critical Care, but there's an interesting article in here about a research study that was done regarding the measurement of oxygen content in mixed venous blood. And what have we always been taught? Stephanie, you'll probably know the answer to this. What have we always been taught about how long it should take us to draw a mixed venous sample from a swan? I mean, are we drawing it fast or slow? Slow. Right. And that's what I've always been taught. You should draw it with over 1 to 2 minutes. Well, this article questioned that, and they did a research study that showed no significant statistical difference between withdrawing the sample within 5 seconds or 2 minutes. So that is interesting, and what it said is that the prior research and prior studies were done with the catheter and wedge position. So that could be why we're getting different results. So just something to question. When new research or new literature comes out, it may prompt you to create a question, it's called the PICO question, and start an evidence-based practice project. steps of evidence-based practice. And the first is to cultivate a spirit of inquiry. So think about what we do at the bedside and what questions you might have. And then you're going to form the clinical question. You're going to do a literature search. You're going to appraise the evidence. And then you need to integrate the evidence with clinical expertise and patient preferences. And then you always evaluate the outcomes, and then you can disseminate the outcomes. So forming the clinical question, called a PICO question, and the components include population, intervention, comparison, outcome, and the time frame. And generally the question will read, in X population, how does X intervention compare to Y intervention affect X outcome within X time frame? You won't always have time frame in the question. It depends on the question that you're asking. And the question isn't always going to read exactly like that. It depends on what domain it's in. There's different domains. There's intervention, etiology, diagnostics, prognosis, or meaning. And based on what category the question is coming from, the question can be worded a little bit differently, but it should still have the components of the PICO question. So we'll just do a little bit of practice. So here's a practice question. For patients awaiting CABG, does an intervention program consisting of pre-surgical home visits and follow-up calls from a specialist cardiac nurse lead to decreased patient anxiety and depression when compared with no intervention? So let's just identify the components. Who is the population here? Infancy of CABG. Great. And what intervention are we looking at? And what are we comparing the intervention to? A little bit tricky. We're really just comparing it to no intervention. And what's the outcome? That's right. And is there a time frame in this particular question? No. And what
Could be until you had a cabbage, until you actually got in there.
It could be, or you could say 7 days prior to CABG, you could add it to the question. What domain is this question from? Is it meaning, intervention, etiology, prognosis? Yeah, intervention. We'll do one more practice. For elderly patients with end-stage heart failure, what is the 10-year morbidity and mortality prognosis of heart transplantation after the age of 60 years old compared to recipients less than 60 years old? So who is the population? Yes, elderly patients with end-stage heart failure. And the intervention? Heart transplant, yeah. And the comparison, what two groups are we comparing? Right. And the outcome that we're looking at? Yeah. Morbidity and mortality prognosis. And is there a time frame in this question? 10 years. And what domain would you say this question is from? Prognosis. Correct. Good job. I wanted to highlight that there is, when you're doing a literature search, there's a hierarchy of evidence that you need to take into consideration. At the very top of the chain are systematic reviews, and also, it doesn't say it here, but meta-analysis. That's where you should start if you can get your evidence from systematic review or meta-analysis. That's wonderful. Not all questions are going to lend themselves to that, or maybe there's not enough research and you may not be able to come across that. But a systematic review will take randomized controlled trials and pool them together for you in a review to look at. A meta-analysis is a type of systematic review that will take data from several different trials that have the same outcome measures and pool them together to increase your sample size. And you always want a higher sample size. And then moving down the chain, you have randomized control trials where the subjects are allocated randomly to groups. Non-randomized control trials where there's a comparison group but they're not randomized. And then at the bottom of the chain, you have a case report.